Okay, so good day, friends. The last time we started by looking at hematological malignancies, okay, where I spoke about the possible causes of increase in WBC levels, okay. So I spoke about proliferative disorders of WBCs, and I said they can be induced by inflammation or any challenge to the immune system. We also spoke about leukemia reaction, and we proceeded by looking at some important, I mean, causes of hematological malignancy. Of course, we said hematological malignancy occurs when malignant cells, okay, pushes the normal hematopoietic stem cell from the bone marrow and uses the marrow to, cause more proliferation of malignant cells. So it results in production of immature cells instead of the normal mature cells. Okay, and I show you pictures of the hematopoiesis, and we also discuss more into the various types of hematological malignancy. Today we want to look at leukemia. Okay, leukemia, very very important. Leukemia. Now leukemia is a example of hematological malignancy, but this is restricted to the hot WBCs, you understand? So cancer to the blood cells in the bone marrow, you understand? So classification of leukemia, we have if you want to classify leukemia, you can do that by considering the full blood count results. Okay, so let's say a patient visit your facility, and you want to, I mean, you suspect leukemia. Okay, but what type of leukemia is that? So from the full blood count results, okay, we can look at decreased RBC and hemoglobin in peripheral blood. Okay, so you run your full blood count results. Possibly there will be low level of red blood cells and hemoglobin. Okay, and there are two. There is neutrophils and platelets, which levels may be reduced. So that one too is a guide. Okay. Now the levels of thrombocytopenia tends to be more massive in acute leukemia. So the last time I said there are two types of leukemia, acute and chronic. Okay, so for acute leukemia, the levels of thrombocytopenia basically means low level of platelets. Okay, so it tends to be more severe in acute leukemia, and leukocytosis is the hallmark of chronic leukemia. So you see this. So in chronic leukemia, always you see leukocytosis. But remember, not all leukocytosis is a result of chronic leukemia, as we established in the first video. Okay, can be due to proliferative disorders of RBCs, WBCs. Okay. Now, based on the onset of symptoms in a patient, you can classify leukemia into two, or of course, we know the two classification. So, if the onset is sudden, we say the person is having the acute leukemia. But in chronic leukemia, the onset is what? Slow. Okay, very good. Now, you also consider the type of cell that predominates in the peripheral blood and bone marrow, which defines the lineage. Okay, so myeloid cell versus lymphoid cell. Which one is more in the peripheral blood? Which one is more in the uh, uh, um, bone marrow? And this one will tell you the type of maybe leukemia, maybe chronic myeloid leukemia or acute myeloid leukemia. Okay, so the type of cell that's predominates in the bone marrow or the peripheral blood also tells you um, um, the type of leukemia. Okay, now the maturity of the cells. Okay, in acute leukemia they are predominantly blood cells. You see a lot of blood cells. Okay, but in chronic leukemia um, there are a lot of mature cells. Okay, presence of mature cells, very important. Then the age. Basically, acute leukemia usually occurs in children, okay, and the chronic leukemia usually occurs in adults. Take note of that. So if you want to classify leukemia, these factors can also be of guide. The full blood count results to look at for decreased level of hemoglobin, neutrophils, and platelets. And I said the thrombocytopenia, or the low level of platelets, is more severe in acute leukemia. And then leukocytosis, increased level of WBC, is actually the hallmark of chronic leukemia. Very, very important. And then the onset too is very important. And in acute leukemia, the sudden chronic is slow. Okay. So the type of cell that predominates will also tell you that I've spoken about that. So no. Now leukemia can be of two types. Okay. So based on the factors, leukemia can be of two types. We can have chronic and acute leukemia. Okay. Chronic and acute leukemia. Now, let's talk about them. Acute leukemia. When we take acute leukemia, remember, leukemia itself can be classified into two: the chronic and the acute. Okay, and when we take acute leukemia, we are taking the acute leukemia. It can also be subdivided into two. The first one we talk about is acute myloblastic leukemia. This one, acute myloblastic leukemia. This one is telling you that the cell lineage that is mostly affected is the myeloblast. Okay, the myeloid cells, they are mostly affected. Acute myloblastic leukemia. And acute lymphoblastic leukemia. So we have acute myeloblastic and acute lymphoblastic. Of course, acute lymphoblastic leukemia affect the lymphoblast. Okay, so the myeloblasts, you know, the cells that they are going to give rise to. Okay, in my first video I spoke about hematopoiesis, that in the bone marrow we have the hematopoietic stem cell, which differentiates into common myeloid and common lymphoid. Of course, the common myeloid give rise to the myeloblast, the myeloid cells, which further proceed to give us the neutrophils, the eosinophils, the monocytes, basophils, the RBCs, and the rest. Okay, and then the common lymphoid also give us the T lymphocyte, the B lymphocyte, and the plasma cells. Okay, which tends to be more predominant in antibodies. You got the plasma cells actually produce the immunoglobulins, which help in the immune system. Okay, immune system. It's very, very important to know this thing. Okay, so what I'm trying to say is that acute leukemia can further be divided into acute myeloid leukemia or myeloblastic leukemia and acute lymphoblastic leukemia, which is very, 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 very important. Very, very, very important. So, of course, if you know that in leukemia you can have two types: the chronic and acute. And the acute can be divided into acute myeloid and then acute lymphoid. It becomes very important to, understand the concept. So please, if you start watching this video, just go back and watch my first video on how hematopoiesis occur, and you understand the genesis of leukemia. Okay, very important. Now, the chronic leukemia can be grouped into two: chronic myeloblastic leukemia and chronic lymphoblastic leukemia. You understand that? So this one is telling you that in chronic myeloblastic leukemia, the cell lineage that is mostly affected are the myeloblast, or the myelocytic cell, or the common myeloid progenitor cell, which is coming to give us the myeloid cells, are mostly affected. Okay, so in this case there will be a lot of blast cells in the peripheral blood of the bone marrow. And then the chronic lymphoblastic leukemia also occurs, and it's mostly affected in chronic leukemia. What you have to understand is that we have two types: chronic myeloblastic and chronic lymphoblastic. Okay, yeah, the same thing as I explained in there. So let's talk about acute leukemia. Acute leukemia. Okay, so in acute leukemia, when we say acute leukemia, okay, for a medical personnel or a clinician or a medical laboratory scientist to be able to diagnose acute leukemia, okay, we say that in acute leukemia, it is basically defined by the presence of greater than or equal to 20% blood cells in bone marrow or peripheral blood. Okay, 20%. So at least let's say the blood cells in the bone marrow is supposed to be less than 5%. Okay, shouldn't be plenty, you understand, but less than 5% or less than or equals to 5%. But then if you view your bone marrow smear or peripheral blood smear and you observe more than 20% blood cells, it is telling you that no, this patient may experience or may be having acute leukemia. Once again, I want to repeat that it is very important as a medical laboratory scientist to be able to identify the type of cells in a disease state. You understand? So I'll show you some pictures that present with the blood cells in peripheral blood. Okay, so as we proceed, I will speak about some characteristics that we use to classify the blood cells, so that we can observe them under the microscope. In most developed countries, they rely much on other lab tests in diagnosis of leukemia. Okay, for instance, some labs may use cytogenetics. Some labs may use let's say fish technique. Okay, some labs may use karyotyping, because they want to detect the exact gene that is being affected, but in our country, the only reliable sources, not in all facilities, but in most facilities, the only reliable source is the microscope. So this microscope, if you're a scientist and you sit at the back of the microscope, you have to be well developed or well mature that you can be able to differentiate blood cells from what? Matured cells. Understand that? So when you come to acute leukemia, remember that you have two types. We have the myeloid leukemia, acute myeloid leukemia, and the chronic myeloid leukemia. What we are trying to say is that in leukemia in general, there is a presence of about greater than 20% blood cells in bone marrow or peripheral blood. Now the key point here is blood cells. Somebody may ask, what are blood cells? You remember my first video when I was explaining hematopoiesis? I said that the common myeloid progenitor cells will differentiate and give us the blood cells, which of course we have the myeloblast, metamyelocyte, and those ones, which will proceed to give us the mature cells, which are found in peripheral blood. Example is the bound neutrophils and the neutrophils. Okay, so the blood cells are not matured, unlike the neutrophil, which has about 3 loops of segmentation. The blood cells, some of them have nucleolus, some of them have large nuclear, so we compare them by using the nucleus cytoplasmic nucleus. I'll show you pictures of that, you appreciate that. Okay, so in leukemia, that is that. Now, how can you differentiate acute myeloid leukemia from chronic myeloid leukemia? In the lab, in most labs, specialized tests are needed to confirm this. Okay, so in most cases there are cytochemical stains, There are also some genetics that they use, DNA microarray and those stuff. They use that. But in our part of the world, we concentrate much on the cytochemical things in the microscopy. Okay, and remember that acute leukemia affects mitotic cells. Okay, it affects mitotic cells, and mitotic cell that can proliferate to give rise to other ones. Okay, so because acute leukemia affects mitotic cells, it can kill easily. Okay, can kill because the cells are proliferating, and when there's leukemia, more proliferation, and the symptoms can be severe and to be more fatal. And acute leukemia can also be treated when it is being diagnosed early. Okay, because it's affected mitotic cells. There is a classification of leukemia, acute myeloid leukemia. Okay, there's FAB classification and then WHO classification, but that one I won't talk about that. You can just Google and or you can just search. I'll put the link there. You search for FAB and WHO classification of leukemia. I'm much into the laboratory diagnosis, okay, for this video. So this one so you can go through this. This is the WHO. This is 2008, but there are other new versions there. Okay, so I won't talk much about this classification. So let's talk about acute myloblastic leukemia. Okay, acute myloblastic leukemia. Now the cell lines that is affected is the neutrophils, the basophils, the eosinophils, and monocytes. These are all WBC. Remember that the myeloblasts or the common myeloid progenitor cells give rise to all these mature cells. Okay, so all these things are affected. So in leukemia, for instance, if you run a full blood count, you may have low levels of all these cells. You understand that? That is why I first explained other causes of increased level of these values. So what I want you to understand is that in acute leukemia, the neutrophils are the cell lines that are mostly affected. The basophils are there. So the mature cells, which are supposed to be seen in peripheral blood, are mostly affected. Okay, so in peripheral blood of any person, the normal cells are, you can see the bound neutrophils, you can see the neutrophils. Okay, they are there. Sometimes you can see the basophils, the eosinophils, and those monocytes. These are the normal cells in any healthy person. Okay, so if I'm sick and if I'm not sick and I visit the facility, they prepare a thin blood film for me, these are some of the normal cells that must be seen. And you can differentiate bound neutrophils from the hot neutrophils based on their segmentation. Okay, very important. Now the abnormal cells seen in peripheral blood of acute leukemic patient includes this. So this one is very important. In acute leukemic patient, this is the normal cells, abnormal cells that is likely to be seen in the peripheral blood. We have the myeloblast, promyelocytes, myelocyte, and metamyelocytes. These are immature cells. Remember that during hematopoiesis, there is immature cells which are in the bone marrow. Okay, and they will give rise to the mature cells which will be seen in peripheral blood. And there's under no circumstance in any normal person that immature cells will be seen in peripheral blood, except in malignancies like acute leukemia. So in acute leukemia, these are the cells that you are going to look for in the bone marrow smear or the peripheral blood smear. Remember that. Okay, and it's very important as a scientist to know the shapes, the nuclear element, the cytoplasmic elements of all these cells, so that if you are viewing something under the microscope and you come across them, you get about greater than 20%, you can say that no, this patient is a leukemic patient. And which cell lineages the leukemia is affected. then you can say it is the health acute myeloid cell lineage. Okay, myeloid cell lineage. This is very important, very very important. So the cells are differentiated based on, so how can I differentiate myeloblast from promyelocyte, myelocyte from metamyelocyte? You understand that? One thing that we use is the nuclear to cytoplasmic ratio. Nuclear to cytoplasmic ratio. The nuclear content to the cytoplasm. If you compare it, what's the ratio? The ratio, okay? And then look at the overall cell size, the nuclear characteristics and the cytoplasmic characteristics. So I'll talk more about this one. So if you take promyelocyte, it has a high nuclear to cytoplasmic ratio than myelocyte, okay? So promyelocyte has a high nuclear to cytoplasmic ratio than myelocyte, and of course promyelocytes contain nucleolus, which is, and there's more nucleus, okay? So if you compare promyelocyte to myelocyte, you see that the nucleus is large and the cytoplasm is small, okay? And sometimes there are nucleolus present, unlike myelocyte, which has, okay, the nucleus is also high, but not as high as in promyelocyte, okay? So that's why we say that the promyelocyte has a high nuclear to cytoplasmic ratio. Very important. And then metamyelocyte, there's no nucleolus and the nucleus is very small with high cytoplasm. So when staining or washing slice, appropriate buffer must be used to make the pH, to make sure that the pH does not impart color to the slice, okay? So this one comes to technicalities when you are working in the lab, okay? Because if the pH is acidic, it can impart different color to the slice, and if it is basic to the same thing, so you maintain a specific pH for the stain so that it can stain properly and make accurate diagnosis. Okay, very important. So the mature cells are very important, very very important for you to know all the mature cells. I'll give a picture of them, and so that you'll be able to appreciate them. Now, clinical features of acute myeloid leukemia. So a patient with acute myeloid leukemia, you see the patient will present with anemia, pallor, hypoxia, those symptoms of anemia, okay? You see that. There is thrombocytopenia, okay? The platelet levels are low, okay? Platelet levels are low. Yeah, such a patient. There is gum hypertrophy. There is neutropenia, low levels of neutrophils. There is medullary infiltration, that brain infiltration. There is, because of the malignancy, they can infiltrate the medullary, and of course organomegaly, okay? There is high or increased levels of organs. They expand, okay? Like hepatosplenomegaly, the expansion of the liver, and the spleen, because of organ infiltration, okay, of the malignant cells. So the laboratory findings in acute myeloid leukemia. Laboratory findings in acute. What will you see as a laboratory scientist? FVC results may be variable, so you don't have to judge, okay? Maybe the patient may present with clinical features, okay? Like, this is what I want to say. When a patient visits the hospital at early stage of the onset of the leukemia, you see that you run a full blood count, but the patient may not present with clinical features like the anemia, like the thrombocytopenia, like neutropenia, because the time of the onset and the time that the patient came, the malignant cells has not begun to initiate their effect. You understand that? So you not see any clinical features of anemia and other stuff on the, but that doesn't mean the patient is not leukemic. So what can you do? You have to go and search for the black cells. So the black cells may be seen in peripheral smear. Okay, so that is why there's the need to prepare the thin smear, and it is very important for all laboratory scientists to be able to know how to prepare the peripheral smear, because that one, when you prepare it, it will expose you to know all the cells, okay, all the cells, including if there is malignancy, you see the malignant cells. Very very important. But then when you want to prepare a peripheral smear or a thin smear for someone you suspect of acute myeloid leukemia, okay, you are going to look for the blood cells, okay. But remember that if the patient is leukopenic, there's low level of WBCs, you may not see the blood cells, okay, because the blood cells are WBCs, and if there's low level of WBCs in the smear of the patient, you may not see. So here it comes with a lot of technicalities when working in the lab. Let's say I visited your lab and you suspect all clinical features of leukemia, but then if you look at my full blood count results, you see that there is leukemia, okay. Now you want to prepare a thin smear for me, and you took my blood sample. That is what we are trying to say. If you use that blood that you took, the peripheral blood, you may not see the blood cell because I am leukopenic. I have low level of what? Blood cells. You understand that? So then what do you do? What do you do? We talk about that in no time. Now, cytoplasmic inclusions called ROS are present in small fractions of myeloblast, monoblast, and promyelocytes. So you may also see cytoplasmic inclusion. This one, the ROS, they may be present in small fractions of myeloblast, monocytes, okay, in peripheral blood. And you see nucleated RBCs in peripheral blood. Now, people confuse themselves with nucleated RBCs and then RBCs. It is very, very important to know nucleated RBCs. They are not, it resembles RBCs, but the only difference is that for the nucleated RBC, it has nucleus. You understand that? And it has a central payload. Remember, the RBC also have the central payload, okay. But nucleated RBC also have the central payload. Just that the nucleated RBC has nucleus that take out the stain. That's the only difference. So the nucleated RBC will stain, and the central payload may be there, but the RBC will not stain because it doesn't have the nucleus to pick up the stain. You understand that? Good. So there will be normocytic pneumochromic anemia, thrombocytopenia. There's high levels of serum uric acid and LDH. Somebody may ask why? Because in leukemia there is destruction, or there is formation of more malignant cell, okay, and this malignant cell tends to increase the level of serum uric acid and lactate dehydrogenase, because once there's malignancy and the mature cells are being pushed away from the bone marrow, okay, the malignant cells tend to produce, or from the breakdown of the mature cells, you're going to get a lot of uric acid and lactate dehydrogenase, okay, very important. Now, bone marrow smear. If you want to prepare bone marrow smear for acute myeloid leukemic patients, this is what you expect. The bone marrow will be hypercellular with 20 to 80% blood cell, because if in peripheral blood you get about, let's say, 20%, you expect more in the bone marrows, okay, so 20 to 80% blood cells. Now at least you have to count 500 WBC should be counted for bone marrow smear when estimating blast percentage, okay. It's very important. So you count about 500 WBCs. Now if WBC is 2.0 times 10 to the power 9 liters, that is if the patient is leukopenic, because if your WBC is less than 2.0, it means that there's a low level of leukocyte, which is leukopenic. So this is a point that I was talking about there, okay. So in this case, what you have to do is that if you use the peripheral blood to prepare the thin film, you may not see the blood cells, okay. So you use the Buffy coat for the smear preparation for differential counting. What is Buffy coat? When you take a blood from a patient and you use your centrifuge, okay, after centrifugation you see that there is layers, okay. So the first layer will be the plasma, the sediment will be the the RBCs, the area between the plasma and then the WBC, okay. comes the Buffy coat, and that Buffy coat contains a lot of WBCs. So technically, you use the Buffy coat to prepare the smear because the patient is leukopenic. So don't just say that I ran FBC for this patient. We suspect leukopenia and the symptoms or features of leukemia, but then after I prepared my smear, there are no blood cells, so the patient is not. But then the question is, which sample did you use for the smear preparation? Even though the patient is leukopenic, and you go ahead by telling me that it is peripheral blood, then there's no technicality here, So there's the need to use the Buffy coat when you suspect leukopenia, okay, so that you see a lot of the blood cells. So this picture tests it all. This is a thin smear, okay, a thin smear. Let's say in the peripheral blood. These are all white blood cells. Can you see that? The white blood cells with the central pillar. Can see that? Okay. So the big cells here, they are all blast cells. Okay, blast. At the normal circumstance, this one shouldn't be seen in the bone marrow or in the peripheral blood of a normal patient. So you see that, look at these cells very well. You see the nuclear to cytoplasmic ratio. This one is very high. So this one can be myelocytes. This one too is very high. So if you prepare your peripheral blood smear of a patient and you see all these blood cells in the bone marrow, okay, it's telling you that the patient is having leukemia. And these blood cells are from the myeloid cell lineage, the myeloblasts, metamyelocytes, those ones, because of their nuclear to cytoplasmic ratio. Okay, when we get to acute lymphoid leukemia, I will talk about that. So it's very important to know that. Okay, so as a laboratorian, you have to be able to differentiate this one. That's why the preparation of a thin smear is very important. Sometimes in the lab, you'll be rushing, the patient is in hurry, so let us prepare thick film for the patient. Do that, you'll not see anything. Remember that quality healthcare is our priority. So we take our time, prepare the thin smear. If you suspect anything like leukemia, you want to see something like this. Very important. So look at these two pictures. This is a normal bone marrow smear, okay? Bone marrow smear. So this one even give a clear picture of the monomorphic. This is a monomorphic picture of the peripheral blood showing of acute lymphoid leukemia patient, okay? So this is a normal bone marrow, you have to see this. But in acute myeloid leukemia, you are going to see this. There's greater than 20% blood cells. So you see this one. These are the blood cells. See where they're pointing? These are the blood cells. These are blood cells. These are all blood cells. Okay? Blood cells. So a lot of them greater than 20. And this one shows that the patient is having acute myeloid leukemia. Very important. So I will end this video on acute lymphoid leukemia. I hope this video is useful and it will help you. Try to subscribe to the channel for more videos. Thank you.